I don't know. So good morning, everybody. Today we have Dr. Aneesa to take us through the treatment of myositis. Last talk, she spoke on the introduction, classification, the various etiologies, the pathogenesis, and clinical features. Now, after she'll just recap the last lecture in a few minutes, and then we start with the main topic, which is treatment of myositis. As you all know, Dr. Aneesa is a consultant rheumatologist at Dhirubhai Ambani Hospital, HN Hospital.
No, ma'am, Sefi Hospital. Yeah.
Sefi, and at Sefi. And she has her own clinic at Opera's. So over to you, Aneesa.
Sure. I'll just quickly recap last time's talk, which was the approach to a patient with inflammatory myositis. And we had started with a case initially and talked about a 44-year-old lady who basically had myositis initially and then was detected to have what we call anti-synthetase syndrome, which is basically a combination of various things such as nodes, fever, arthritis, as well as ILD. Then we talked about different phenotypes of myositis, for example, the polymyositis, the dermatomyositis, and anti-synthetase syndrome specifically, and also inclusion body myositis, necrotizing statin-induced myositis, and cancer-associated myositis. We talked about how dermatomyositis comes with florid skin signs. Some of them we have studied about since our MBBS days, such as Cotron's signs, Cotron's papules, the shawl sign, and of course, periungual erythema, heliotropic rash. These are very important to identify a patient clinically. We also talked about the different antibodies, which are very, very important, and I'll touch upon them in this lecture also. Going forward for the diagnosis and also for treatment and prognosis of myositis patients, these myositis-specific antibodies have made a huge impact in our approach to these patients. We talked about how muscle biopsy still has an important role, but we don't use it as often because of the use of these myositis antibodies which are available. And we still use a biopsy when we are in doubt about the diagnosis, whether the patient has polymyositis or whether the patient has something more sinister like a necrotizing myositis, or whether it is some other differential diagnosis altogether. And that is when we use a muscle biopsy to differentiate between these different phenotypes. We also spoke about how the tests, such as, of course, we do the ANA, but also the muscle enzymes, such as total CPK, LDH, which help us not only to diagnose, but also to monitor and see the treatment efficacy of our medicines. We spoke about how as mentioned, that the antibodies have not only impacted the diagnosis, but they also help us to decide which drug to use. And I'm going to touch about that on that today. So starting with that, I think I'll start with my talk. I'll just share my screen. Just 1 minute. Yeah. Okay. So I hope my screen is visible. I'll start about how we will now manage a patient who we have diagnosed with inflammatory myositis. So again, I'm going to touch upon the same case that I talked about last time, about this lady who comes with polyarthritis, fever, respiratory symptoms, muscle weakness. And then based on her clinical features as well as her antibodies, we diagnosed her with anti-synthetase syndrome. She initially had very high muscle enzymes of 9,000 plus. Also elevated LFT, which were not coming from the liver, but were actually coming from the muscle itself. And so initially there was a diagnostic dilemma, but all of this was found to be later myositis. She had anti-PL7 antibody and anti-Rho52 antibody positive in her myositis specific profile. Over the last few years, she received different treatments, initially methotrexate, but then developed oral ulcers. Then she was also put on azathioprine, but that was not working. And then finally, she was given rituximab because of refractory disease, to which she responded. Over the years, she then again required maintenance therapy with mycophenolate, tacrolimus, and even tofacitinib was tried. But finally, she again had a severe flare, and again in 23, she required rituximab. Before I go on to the treatment, I just do want to say that this disease, although we do know a lot more about it, it still remains a very rare disease. And as some may have seen in the headlines today, a very sad news about Suhani Bhatnagar, a 19-year-old actress who unfortunately passed away with dermatomyositis. Just wanted to mention that it's a extremely sad news, but also goes to say that despite having all these treatment options, this disease does remain a difficult one to treat. Coming back to how we should approach a patient with myositis. Broadly, I think it is important for us to remember that treatment is still categorized into pharmacological, non-pharmacological, and then, of course, invasive treatment options. Just as we approach any disease, I think these three subtopics help us to remember everything. So pharmacologically, of course, most rheumatological diseases and even myositis is initially treated with glucocorticosteroids, but then we have to add steroid-sparing agents and then escalate or de-escalate depending on a patient's response. Non-pharmacological treatment is very much important, and I'll touch upon that in the later slides. And sometimes, despite all our measures, if patients do develop certain complications, we must add on surgical mechanisms of treatment, such as maybe a PEG tube or nasogastric tube. So in our treatment armamentarium, we have lots of options these days, but how to use them and what is the evidence for their treatment still remains a difficult thought process. We have all these options and the evidence for all of them has been given. This being a rare disease, there are not as many trials and not as much evidence out there. So many a times we do have to take an individualized patient-specific approach and take decisions depending on our individual patient problems. This is a nice slide which tells you that depending upon the organ involvement, if you remember last time we mentioned that this disease, although it's called myositis, can also affect the skin, the lungs, the arthritis manifestation, as well as GI manifestations. So depending on their various manifestations and depending on their various antibody profile, we might be able to choose drugs which may or may not work for them. So this slide, although a bit complicated, does help you decide which drug may work for which particular physical manifestation. This is a very important slide, and I had mentioned it in the last presentation as well. I brought it out here again because I think going forward, as trials, more and more trials and more research comes out, we will find that these myositis-specific antibodies, which are basically at the moment helping us decide what organ manifestations these patients will have or what will be their prognosis down the line, they will also help us to decide which pharmacologic treatment will work for them. So what should be an approach to a treatment, or how should we sort of enumerate our goals? I think the most important goal, as with any disease, is to make an accurate diagnosis, to make sure that we know exactly what we are treating. Only then, of course, the treatment, what we decide, will work. Explaining and communicating is very, very important. No matter how good we are as doctors, unless we are able to get our patients to understand their disease and also to understand the long-term implications of their disease, no matter the best medicines may not work. Enumerating the prognostic factors. So all patients are not the same. All patients may not come early to us. So also knowing realistically what are the prognostic factors and how well they will do with treatment. Defining disease activity and damage. All rheumatologists talk about these two terms, and I'm going to talk a little bit more about them. And of course, most important, individualizing the patient's approach. So again, talking about the differential diagnosis, because myositis, although it sounds easy enough, but there are many other diseases which can either complicate, confound, or confuse our diagnosis. You still have all your metabolic problems, your electrolyte disturbances, your metabolic disorders of carbohydrate or lipid metabolism. And of course, drugs, many of our patients are put on glucocorticoids. So some amount of their muscle weakness may be coming from the corticosteroids. And of course, all the complications as well as infections which cause myositis. So before we jump to a conclusion and immunosuppress our patients, we must know that it's none of these other factors that we are dealing with. And it's important to rule out these things first and foremost. So what is the basic principle? In all rheumatological diseases, especially connective tissue diseases, we always approach patients with therapy with these basic thought process. That first we must induce the therapy, that is rapidly decrease the inflammation and induce remission, that is known as induction therapy. We must then maintain this induction by giving medicines to maintain the remission. And of course, what is clinical remission? That should be our goal of treatment, although we may not always achieve it, but we must strive for it. That eliminating all disease activity from all organ systems. So, for example, a patient with myositis may also have ILD, may also have skin involvement. We must look at the patient as a whole and not only target one organ. There are certain factors which do predict a poor prognostic outcome. So, for example, someone presents to us much later in their disease where they've already developed disease damage or muscle atrophy, or they may have come at, or the disease may have manifested at an older age. Also, sometimes they have a lot of other extramuscular manifestations such as dysphagia, calcinosis, maybe a cardiac complication. These, of course, do have poor prognostic outcomes. And also the phenotype depends. So inclusion body myositis, as we had studied last time, it has a poorer outcome compared to dermatomyositis, which is much better. Certain antibodies, again, like anti-MDA5, anti-SRP, they do have a poorer outcome versus the anti-synthetase antibodies. So all of these will, help us decide and help us also realistically tell our patients about what they should expect from the treatment. So what is activity and damage? If anyone has, ever seen a rheumatologist talking to their patients, these words may have come up. So disease activity basically means that the disease is still actively, that organ is still actively inflamed. For example, in muscle, there will be active inflammation, but this is potentially reversible. So this is a good thing that we can give medicines, immunosuppression, and reverse it. For example, it can also be arthritis, it can be skin rashes, it can also be active muscle weakness, which is changing from one visit to the other, or they can have high muscle enzymes, inflammatory markers, anemia. All of these factors will help us decide if a patient has ongoing disease activity. Versus if a patient does not have these symptoms, does not have raised inflammatory markers, and still has muscle weakness, it may be that the patient has undergone disease damage, whereas the muscle has undergone fibrosis or scarring. Or, for example, in a skin, there's no active inflammation, but there's skin scarring. These things are much more harder to treat and they may not improve. So it's important to know at the beginning of starting treatment how much is disease activity and how much is disease damage. So talking about the various treatments, there are plenty of options, but knowing which one to decide, I think, is the key. And sometimes it may be difficult, but we'll go through all the options that are at the present available. So as with many of our connective tissue diseases, specifically corticosteroids are initially used. They are, of course, a double-edged sword, but we do require them in the beginning to induce, as I had mentioned earlier, induce some sort of remission. So depending upon the disease severity, we may use oral or IV steroids. Oral is generally preferred as far as patient can swallow and patient has not too much of GI involvement so that absorption is not affected. The doses, as we know, we start at either 1 to 2 milligram per kg per day. Although previously we know that single daily dose is preferred, but sometimes we might have to divide the dose because if the dose is really high, they may not be able to tolerate one single dose. If there is major organ involvement, for example, either pulmonary, like severe active ILD with a lot of ground glassing, or they have dysphagia, or they have cardiac involvement, we might have to use what we call pulse steroids or IV steroids, where we generally give a 1 gram per day dose for 3 consecutive doses. All this has to be done under expert supervision and it has its own side effects. I don't need to mention all the toxicity of glucocorticoids. All of you all are very well aware about them. We've been studying about them from our MBBS days. Everything from osteoporosis, vertebral fractures, avascular necrosis, metabolic problems such as diabetes, Cushing's, all of this is a major complication, especially of long-term high-dose steroids. This is important to know. So it's important that as patient gets better, we must taper the steroids. We must monitor not only their clinical response, but also look at their CPK and their muscle enzymes, which help us identify if the patient is responding to treatment. One major complication of corticosteroids, especially in myositis patients, is that they develop steroid myopathy. This happens more so in our Indian patients and I think in Western patients because we respond to steroids far more than the Western counterparts. As a result, as the patient comes to you, the muscle weakness may actually worsen, although their CPK is getting better. And we must then think of steroid myopathy, which is not, in the sense, is different from myositis because it involves the lower limbs and the quadriceps much more than your myositis. So this is a diagram which we are all very well aware of, and we know all the side effects of steroids. And every time we talk about using steroids, we must keep these in mind as well. The second drug which we use very commonly is methotrexate. We use this in many of our rheumatological diseases, but also works in myositis. And it has to be used it can be used either orally or we have a subcutaneous option available. Always use it with folic acid. We start at a slightly lower dose, such as 15 milligram per week, and then can increase it to 25 milligram per week, depending upon the tolerability. So although it has a lot of possible side effects, but if used correctly, actually methotrexate is a very good drug, which most of us are very familiar and comfortable with. But we must remember that it causes a lot of nausea, sometimes vomiting, GI intolerances, even diarrhea. And we must look out for cytopenias and hepatic toxicity. The important thing is in myositis patients, often the SGOT and PT, the transaminases, might be elevated. This is not coming again from their liver, but it's coming from a myoblast activation of the myositis itself. As a result, it might get confusing and one may think that methotrexate is causing this toxicity. But looking at all the reports in a sort of a timeline will help us understand whether it's because of methotrexate or the disease itself. Methotrexate has been blamed for pulmonary toxicity, and this is a pet peeve of all our rheumatology colleagues, where the chances are really less common. And especially in myositis, it's important to remember because patients may have mild ILD, we may still use methotrexate, and the chances of pulmonary toxicity is very, very less common. Azathioprine is another drug which is often used in patients with myositis. It can be used even in combination with methotrexate, but of course, again, the monitoring becomes very important. The onset of action is a little slower, so you might have to give steroids for a longer time with azathioprine. It also causes a lot of GI intolerance sometimes. Cytopenias and hepatotoxicity similarly have to be monitored. IVIG is an important drug, and one must remember this because it can be used in life-threatening situations. So, for example, if a patient has severe respiratory muscle involvement or dysphagia, we might have to use IVIG in an emergency fashion. Of course, trials have shown IVIG even to be used as a maintenance therapy in patients with dermatomyositis. But this being such a costly drug, in our Indian setup, this may not be possible. But we sometimes use it in an acute setup just to bridge the therapy because before our immunosuppression starts working, or for example, if a patient has a lot of infection, before we can give them immunosuppression, we might have to use IVIG just to buy time till the antibiotics start working, and then we can give the immunosuppression of choice. We generally use the same dose which we use in many of our other diseases, that is 2 grams per kg, and we divide it over 2 to 5 days. It's quite costly still, and the small possibility of thrombosis has to be kept in mind. So these patients have to be hydrated very well. The good thing is it works fast. So again, in a critical situation, it might be life-saving. Mycophenolate is also a good drug, but it cannot be used in women of childbearing age. Similarly, sorry, should I mention methotrexate also? We cannot use this because it has teratogenicity. And in patients with ILD and also skin involvement, mycophenolate is a very good option because it specifically helps acute ILD. But again, the onset of action is slow, so it starts working only after about 6 weeks. We start usually with a lower dose and then gradually build it up. Maximum, we can go up to 3 grams per day. But most patients don't tolerate higher doses. They get a lot of diarrhea, gastric discomfort. That's why it has to be increased very slowly. Infections, again, are a real problem. And ideally, these patients should be vaccinated and looked out for any infection before we start it. Cycloserine and tacrolimus have been used also in refractory cases of myositis, but they have a very narrow therapeutic window and therefore need a lot of monitoring. Hydroxychloroquine is used especially with patients with skin involvement like dermatomyositis, and also in those who don't have, who have DM sign myositis. DM sign myositis mainly means that they have all the typical clinical features of dermatomyositis, but they don't have muscle involvement. So it's only skin predominant. And in these patients, if we don't want to give them higher immunosuppression for whatever reason, maybe it's contraindicated, hydroxychloroquine is a good option. But just a small note from a very clinical perspective, hydroxychloroquine in our Indian patients causes a lot of skin hyperpigmentation. So sometimes trying to improve one thing, we might cause pigmentation, and something we need to address if it happens. In patients who have very severe myositis or those who have interstitial lung disease or vasculitis, we might also need to give cyclophosphamide mostly as an induction therapy. This is nowadays used more IV. Earlier, we did use a lot of oral cyclophosphamide, but it has severe side effects which have to be looked out for, such as hemorrhagic cystitis, cytopenias, and of course, in women, it can cause infertility. So in younger women, before using cyclophosphamide, we have to be very careful that we have ruled out all other options. Most often, we try not to use it. And if we must, then we must counsel them upon its side effects. The new drug, Rituximab, the relatively newer drug, it's been around for a long time, which we use in a lot of other diseases such as rheumatoid arthritis and lupus. We also know that it does work in certain patients of myositis. So selecting the patient is important. If we give it a blanket to all patients, this may not help. Some trials, such as certain trials, have shown benefit, the known as a RIM trial particularly, but the overall trial did not meet the endpoint. But it showed that 80% patients who received rituximab benefited. This was a long time ago. Since then, there have been a lot of data, which yet it has not led to an approval of using this drug. But those who have certain antibodies, such as anti-Jo1, anti-MI2, we might find that these patients respond better. So this is where, again, I'll go back to my point that the antibodies not only help us to diagnose, but also to treat these patients and decide which drug works for them. Especially in patients of juvenile dermatomyositis, patients who have ILD, and those who have come to us early with less disease damage or less muscle atrophy, for them, we might use this drug, but we must at the same time look out for infections. We must vaccinate our patients, and we must monitor them regularly for complications. So broadly, we divide these sort of drugs into first line, second line, and third line therapy. This is a very broad overview, and we don't always necessarily stick to it. If someone comes with very severe disease, we might sort of escalate the therapy higher rather than following this approach. Initially, of course, glucocorticoids are used. Then we might use methotrexate or azathioprine. In those who don't respond and we can't taper the steroids, we might either add or change to mycophenolate, or we might use a combination therapy. And finally, in those who either have very severe disease or refractory disease, we might choose rituximab. So this is how we use it. IVIG is never the main treatment, but it's always used as a bridge therapy. So this is a nice chart which we can use to sort of remember the order of drugs that are used. Now I want to highlight and talk specially about non-pharmacological treatments. Often as doctors, we forget these things which are equally, if not more important, in treating our patients. So not only counseling a patient, but also counseling their caregivers or their family members is important. Especially in our social setups of sometimes we might concentrate on the patient but forget about, for example, their, if it's a woman, their husband or their parents, who if unless they all understand this disease, they will not be able to cope with the treatments. So helping them not only understand the disease but also to cope in their day-to-day activities might go a long way in patients accepting their diagnosis. Especially in our social setup, women have specific issues such as, for example, in a woman of childbearing age who's married, we cannot straight away give them methotrexate, mycophenolate, and definitely not cyclophosphamide. So it's important to understand this. And if it has to be given in a life-threatening situation, then we must understand and counsel them about their future reproductive health. Also, there are nowadays various patient support groups. Even in India, we do have Myositis India, and it's there is a handle on Instagram as well. There are various patient support groups, and it's important to refer these patients to these groups because they may not be aware about them. Also, setting realistic goals. We cannot be too negative, neither should we be overtly positive and tell patients that they'll be completely okay, especially if they have a lot of disease damage. So this is where the activity versus damage part comes in, and we can tell our patients realistically what they should expect from treatment. So rehabilitation used to be a controversial topic, but nowadays we are much more clear about its uses. Bed rest is only during the very severe phase of myositis. Once a patient has recovered and the inflammation or the disease activity has reduced, they must start a rehabilitation program to improve the muscle strength. This will go a long way to counter not only the myositis part, but for example, due to corticosteroids, patients put on a lot of weight. And this will help them to lose that weight to help with the metabolic side effects of our corticosteroids. It also helps that we must give them a realistic rehabilitation program gradually, where they initially start with an assistant range of motion, maybe with physiotherapy, then they progress with isometric, isotonic, and finally later on with aerobic exercises. If a patient just immediately expects to start running or go back to their normal life, that may not happen, and that may lead to disappointment. So we must give them a realistic program of how to go about it. We can also help to manage their pain. We can help them manage using assisted devices. For example, for patients who have IBM, we might need to give them devices for foot drop or wrist drop. Also important to keep in mind, of course, is that patients will not only have myositis, but they will have other extramuscular manifestations, for example, interstitial lung disease. It's quite common in our patients, and we must always look out for it. Even if they are initially asymptomatic, we must look at their chest x-rays, maybe do a pulmonary function test, and if required, do high-resolution CT scans, because this will change the treatment. Certain medicines like high-dose steroids, mycophenolate, and even rituximab may help to prevent fibrosis and scarring of the lung, and this might improve the patient's outcome to a large extent. We must use a team approach and involve, of course, pulmonary physicians when required, and also focus not only on overall rehab, but pulmonary rehab, which also helps to improve patients' functional capacity. Vaccinations where required, such as influenza and pneumococcal vaccine, also help go a long way to prevent complications such as lung infections. Cardiac involvement is rare. Most often it is subclinical, but when severe, it can present with arrhythmias and cardiac failure, which of course require their own treatment and supportive management. Where required, we must do serial troponin I levels, because troponin T and CKMB will be falsely elevated and won't be a marker of cardiac, but rather it is a marker of myoblast activation. So where we suspect cardiac involvement, we must do a troponin I serially and see how it increases. Also, in these patients, the overall treatment is immunosuppression and treating the disease itself. But of course, anti-arrhythmia measures or measures for cardiac failure may be required. GI involvement is often a major manifestation, and when patient presents with severe dysphagia, this can be a poor prognostic marker because this can lead to aspiration and it requires very aggressive treatment. So this may be a reason to use IVIG in certain patients because these patients who present with dysphagia will probably deteriorate very fast, go into respiratory distress down the line. You might have to put a PEG tube. Again, this is where we have now ascertained that despite treatment, there is disease damage. So in these patients, they may not completely initially recover. So we might have to put in a PEG tube to prevent complications such as aspiration and also to maintain nutrition in these patients. In JDM, sometimes in pediatric patients, sometimes life-threatening perforation, intestinal perforation may occur, which have to be looked out for and treated very aggressively with surgery, IVIG, or high-dose steroids. So another important manifestation of our patients with myositis is skin involvement. Now, this is again what I mean that for a patient, say especially a younger lady, we might treat her myositis, but unless we can treat the skin manifestations, her quality of life may not improve. So we must look at these factors, guide them that they must not go out in the sun, avoid UV radiation, use sunscreens. Their skin is very, very photosensitive. Sometimes topical steroids may be required. You also get topical tacrolimus creams. And in severe cases, those who develop very bad skin ulceration, which can get infected and even can be life-threatening, we must use IVIG again to sort of control the disease. Other drugs which work are methotrexate and mycophenolate, and we can use them where relevant. Another very important complication which we must always look out for is calcinosis. This often requires aggressive treatment because once a calcinosis occurs, it's very difficult to treat it. So we must initially treat the disease itself aggressively. Colchicine, calcium channel blockers have been mentioned as treatment for calcinosis, but they are not necessarily very effective. Sometimes the calcinosis can be very severe, it can get infected, and therefore we might need to remove it surgically, although it can reoccur at the surgical site. So this is again a sort of a difficult thing to treat. These photos are not very good, but the calcinosis basically occurs anywhere, so even in the sites of the dermatomyositis, but also in the fingers, which is known as calcinosis cutis. You might have seen this also in scleroderma, but dermatomyositis also leads to calcinosis. Amongst the antibodies, the anti-NXP2 is notorious to cause calcinosis. Inclusion body myositis is a very difficult disease to treat. I still remember reading when I was studying for my post-graduation, studying in Harrison, that patients of inclusion body myositis initially might do better with, say, steroids, but often then progressively deteriorate. These tend to be anyway older patients, and though the disease is very indolent, it takes sort of much longer to develop versus your polymyositis or dermatomyositis, which is far more acute, but very few treatments work on it. There are a lot of trials going on. Some trials have shown that methotrexate and azathioprine work, but I think overall, we do hesitate to immunosuppress them too much unless their CPK levels are very high or they have certain autoantibodies. Some of these patients may have an overlap. So they might have some IBM features, maybe on a muscle biopsy. This is where muscle biopsy is very important. And they might have overlap with other connective tissue diseases. In these patients, maybe immunosuppression would help. There are some newer trials and newer drugs which are in the pipeline. My knowledge is that we don't have them in India and we don't use them, but maybe down the line, we will have some answers to treating IBM patients. Statin-associated necrotizing myopathy is something which we must all remember. Statins are used very, very commonly in so many patients, and whatever field of medicine you may choose to do, you will always use a statin. So it is an autoimmune myopathy. This basically starts immediately after using any form of statin, where anti-HMGCR autoantibodies are positive. If we suspect a patient to develop myositis after using statins, we can do this test because it is now commercially available in some of the major labs. Why is this important? Why is it important to recognize this? Because this can be a very aggressive disease. It causes muscle necrosis. In these patients, it initially resembles polymyositis, but if we do a muscle biopsy, it shows us severe muscle necrosis and very less inflammatory cell infiltrate. So in these patients, the prognosis is very different from a polymyositis. So the treatment, of course, is discontinue the statin, might need to aggressively treat it with IVIG immunosuppression, maybe rituximab. It's very important to not miss these patients, because if they develop severe necrosis, then the damage is irreversible. So I'm going to try and summarize my talk. I know I've sort of put out a lot of different information out there. This is a slide which I have borrowed from oncology slides, and this is something we are approaching more and more, where traditionally, of course, in say in oncology, the treatment was radiation, chemotherapy, and surgery. Similarly, in rheumatology, it has always been steroids, immunosuppression. But now, as time goes by and we understand our diseases far more, we realize that each patient of even one disease, for example, dermatomyositis or polymyositis, they are not the same. And we must precisely identify what phenotype or what disease they have and accordingly treat that. So as time goes by, autoantibodies or even genetics will help us identify these patients and treat them better. So this is what we call precision medicine. And not only precision medicine, which involves, of course, proteomics, genomics, metabolomics, but also personalized medicine. So we must look at a patient as a whole, not only just their disease. We must identify their social aspirations, their ambitions, and help them to sort of achieve that. What I mean by this, just to give an example, is that in a lady who has myositis, or for example, who wants to get married, we must remember that down the line, they might want to have children, they might want to have a family. So before giving any medicines, we must keep all that in mind. And we must remember that unless we treat a patient as a whole, the outcomes will not be very beneficial. So myositis still remains a very, very difficult disease to treat. And sometimes the decisions are confusing. But I think a team approach, depending upon the organ manifestations, also looking at making sure that the diagnosis is correct. We have not missed any of the concomitant diseases such as hypothyroidism or any other metabolic myopathy is important before we embark on immunosuppression. Immunosuppression is a double-edged sword, and while we might use it to help our patients, we must always look out for the side effects, specifically infections, cytopenias. So I think that's about it. But I'm more than happy to take any questions either from this talk or from the last one.
Thank you, Dr. Aneesa. It was very nice. Actually, you've simplified the topic so well.
Thank you, ma'am.
It's a systemic disease. All our connective tissue diseases are systemic. So we have to all the time be on follow-up. Just look for the lung involvement, the skin involvement, joint involvement, and everything. I just wanted to know about the statin thing. Is it dose related or how is it?
From what I understand, ma'am, it's not dose related. But of course, whatever patients I have seen when statins are started with very high doses, it happens. And it can, I think, theoretically happen even with a lower dose.
Mostly, both CABG and all, they are on 80 milligram of atorvastatin,
Yes,
and
ma'am.
they're supposed to continue it for a year at least. And then sometimes the cardiologist don't realize that the patient is on such a high dose. They forget to reduce the doses. We see patients coming with so much of aches and pains.
Right, ma'am.
So I mean that was one thing that I wanted to.
Right, ma'am.
Any more questions from the audience? Any students want to ask something? Actually, you very nicely touched upon the steroid aspect also.
Yes,
Many a
ma'am.
times we see patients taking steroids at 10 a.m., 12 noon. No, they take it at odd times, and all these erratic timings lead to more side effects.
Right.
So at least about 2 to 3 minutes we have to spend with the patients to explain what time the steroid has to be taken, how particularly it has to be followed, and everything regarding the weight gain, the sugars, and all that. If you tell them in advance, then they are more particular.
Right, ma'am.
Anybody else wants to ask something? Because we have another session at 11 o'clock, so we thought we'll finish 10 minutes before time. You've been using botulinum this thing, botulinum injections. I think that's for mechanic sands, no? That will
Yes,
work in
ma'am.
mechanic.
I have not used it. I mean, it is mentioned in the textbooks sometimes to prevent contractures and I mean, for contractures, but I have not yet used it. Because at least a few patients of mechanic sands who I have seen, they if they come to us early, they actually get much better. I mean, but of course, that is again if they come early.
They
Yeah.
all come too late.
Yeah, true.
Yeah.
Some of the difficult ones of myositis recently was an anti-MDA5 rapidly
That's
progressive
difficult. That's
ILD.
difficult.
Yeah, that was
And
very
it's
difficult.
bad in those patients.
Yeah. So those are some difficult cases I've seen, and also with juvenile DM, if they have calcinosis, anti-NXP2, that is very tricky to treat.
I think we have to be aggressive. Sometimes
Yeah.
we think, "Okay, this will work, this will work, this will work," and we lose a lot of time in that,
Yeah.
We have to, of course, keeping infections in mind all the time.
Yeah. I think one point I forgot to mention, which I should have mentioned, was also about patients with dermatomyositis, elderly patients. We must also look out for any malignancy, screen them
Right.
for malignancy. That is something I should have kept a slide on. But for the students, it's important that elderly person with dermatomyositis, they might develop any malignancy later on. So we might need to screen them before starting steroids.
I think important is to be alert at every visit,
Yes.
Clinically, the basic investigations. Don't ignore small symptoms that the patient sometimes say, "नहीं, ये तो ठीक हो जाएगा, अभी ऐसे कुछ नहीं बराबर हो जाएगा." But it's not like that. Always not like that.
Right.
Whenever the patient complains something, no, it's always not just they want to complain.
Right.
There is
There's
something
something
behind that.
hiding behind. Yeah. Vigilance, I think, especially with connective tissue diseases, we have to always be very vigilant.
With our busy practice, sometimes we tend to ignore these symptoms and we shouldn't actually. Thank you, Dr. Aneesa. So
Thank
nice
you, ma'am.
of you.
Thank you so much.
It was really great having you.
Thank you, ma'am.
Thank you, everybody. Bye.
Bye.